So I should start by telling you what my thoughts are about static navigation and guidance, but I want to talk about minimally invasive surgery. It's not about flapless surgery. It's about using the best technologies available to effect the best result with the least amount of invasion for our patients based on sound biomechanical principles. And here's my agenda. I want to talk about things that you can find your place on the road to success in this technology. What Scott was showing you today was remarkable stuff, but it reflects a 24-year track record. How can we ascend to Scott's level of involvement by Monday? It's not going to happen. So I want to talk about basically a bit of an introduction. I want to talk about a philosophy of CT information. We'll talk about scanning appliances, which Scott talked quite a bit about, and we'll talk about modalities of imaging. And then I want to talk about electronic dissection. How do you take these structures apart? And what about artifact? How does artifact influence the images that we see? I want to talk about guide options and the navigation concepts, and then talk about its diversity in clinical application. And I was really excited to see Scott show some cases that were kind of everyday stuff, not the bizarre, really difficult, only to use this type of technology. So let's start with the introduction. So the first question that we ask, if we can get this to go forward, is let's look at when we started. Scott and I started back in 1988. This is a long time ago. And there have been a lot of iterations and involvement and so on, but I'm showing you this to let you know that Scott and I have had the pleasure of being involved with this for a long period of time, which ultimately culminated in the publication of this book. So the question is this a fad? This is not a fad. This is here to stay. And if we look at the Millennium Research Group and we begin to look at the potential or the influence for guided surgery as well as guides involved in surgical planning, we can see that the expectation is pretty significant here. It's not going away. And the complexity of the process is what you really need to understand. This is not a one-person show. We need to understand that there's a prosthetic dentist involved, there's a dental laboratory involved, there's an imaging center, there's a planning. We need to know the implant manufacturers and their components, guide manufacturers, and the surgeon. And some people here may be the person that does all of these entities. So this is not a simple process. It's actually pretty complex. And if I can give you one bit of advice, become dedicated to becoming a student of this technology. Well, there's a vacuum. People know human nature. We don't like to do new things and work real hard. We're all busy. We have lots of interests. So if you go ahead and you Google laboratory CT planning services, look at the number of hits that you get in this short a period of time. And in fact, last month, it was up to 210 hits. So there are people out there who know that many of us are not going to have the fortitude to see this through to the end. So there are lots of companies out there which are sending things by email all the time. In fact, Rebecca up there, who was a dental assistant, has planned thousands of cases and placed thousands of implants virtually. And in fact, recently, just the other day, I found out that a certified dental assistant is now teaching the software for a major implant manufacturer. And look what you'll be able to accomplish. You just need to spend a few hours and you'll be an expert in this. Well, it's even available in Chinese. So if it's Greek to you while you're learning the process, just switch to Chinese. It'll be just as unfamiliar. So, what do these services provide? What do these companies provide? Well, they're going to go ahead and they're going to reformat the data for you. They'll create 3D images. They'll help you locate and mark anatomic structures. Shouldn't that be our responsibility? They'll even go ahead and they'll place the implants digitally in a plan for you. Now, just to be on the medically, legally safe side, they'll provide an online consultation. And in fact, you'll even get the opportunity to sign off on the approval whether you know the trouble you're getting into or not. Essentially, ladies and gentlemen, they've dumbed down the process. It's a lack of professional respect for us that they have to dumb down the process. So the question is there an emerging problem? And the answer is there certainly might be. And so my definition of the CT technology is that it may be a substitute for experience, adequate training, and sound clinical judgment. And so while this enthusiasm is occurring professionally, we also run a high risk of taking this technology, which Scott and I and many others have worked hard to develop, and all of a sudden it becomes something that we would all not be proud of. So this led me to write an article in the newsletter of AO, and Scott's kind of familiar with the situation, but I really got upset about the fact that there was an exhibitor at the meeting that suggested some of my comments were inappropriate. In fact, having gone back and reviewed what those comments were, I couldn't disagree more. But essentially, what the article refers to is that the CT, its real value, the real value of CT is that it's an informational resource. And it sets clinical performance standards that we all can elevate in terms of the care for our patients and interaction with our colleagues. The other thing that we have to remember is that these scanning appliances need to be accurate, not only in their fabrication, but also in their seating in the patient's mouth at the time of the CT scan. And DICOM conversion is one of the features. Who's doing the DICOM conversion? Who are the people that are taking this information? And what about outsourcing a virtual treatment plan? And here's the take-home message. This technology, if not utilized correctly, gives you the opportunity to deliver an accurately accurate plan or an accurately inaccurate plan as a result of not developing the strategy effectively. So let's talk about this is my view on information. CT is all about information management. It provides us a more accurate diagnosis as well as the opportunity to have a more evidence-based treatment plan. So the value of the CT is that there's clinically embedded information in the CT. And why do we need to learn the planning interactive software? Well, that's because we need to extract this information. So as you become more adept in looking at CT scans, you'll learn more of the features of the software to extract the information that's important to you. And also, the most critical thing, it allows us to set preclinical performance standards and interact with our patients and colleagues in an atmosphere of interdisciplinary disclosure. And I refer to this as collaborative accountability. So let's look at scanning appliances. There are basically three iterations of scanning appliances: either tooth, full contour wax-up, or a trial tooth setup. And essentially, the need for the selection of the scan is based on the need for more information. So increasing edentialism, you need more information, whether it be tooth position, soft tissue position. But we forget the fact that most of the things that are done relative to the development of scanning appliances are space appropriation inappropriate. We've seen wax-ups where the teeth are too small. And so we need to understand that when we have a wax-up like this, the premolars here are certainly not anatomically correct. And when you begin to look and you now measure, how are you going to develop proper implant position based on relative inaccuracies of the scanning appliance? And when you start to now add the biologics of implant placement, add the implant, we're now in an embrasure. How does this happen? It's because we're allowing the laboratory perhaps to make decisions for us that we should be making ourselves. Well, we also have buccolingual contour relationships that are critical. And when we start to look at the buccolingual relationships, take the measurements, and then we look at wax-ups or denture teeth that are kind of ground in position, we fail to realize that the palatal aspects of these are very important in terms of the emergence. And that's exactly what Dr. Gans was talking about relative to abutment selection and the type of tooth form that we're going to have. So these don't work. So we need to understand that alveolar bone and root position is anatomically dynamic. This is a real critical entity for what we're trying to accomplish. So here are the appliances. We have the full contour on the left, moving to the trial tooth setup as you see on the right. This would be an example of using a barium-enriched media in the tooth portion here that can be imaged. But we need to make sure that the appliance is properly seated at the time of imaging. If it's not properly seated, then the vertical calculation of the tooth position is wrong. Well, if we want to capture soft tissue, relative soft tissue position, we want to extend the appliance with our contrast material to capture the vestibular area. And the trial tooth setup, we need to make sure that that denture is seated. We need a bite registration to make sure that that happens. So this is the appliance where there's a differential gradient of barium concentration in the scanning appliance. And of course, we also have one that we can insert fiduciary markers. But inserting fiduciary markers into a poor existing denture is not what we're talking about, because you're going to get bad information. So when we begin to look at these two, we can understand that there are different modalities of CT imaging, which Scott talked about. And we have the multi-slice CT as well as cone beam. And if there was anything that's changed the face of this technology to make its utilization pretty commonplace, it's the cone beam, but they all communicate by DICOM data. That's the critical issue. So now, once we have the scanning appliance and once we're now imaging the patient, well, what type of imaging protocols are available? Well, we have the single scan as well as the dual scan. And essentially, these two features can be used. And this would be an example of a single scan imaging, where we have the scanning appliance here. But I want to point out that over here, these are the images that are accurate. The two-dimensional images are really your take-home source of information. It's the reconstruction, which is really a Photoshop entity, which may be incorrect due to artifacts, processing, or whatever. And many of the images that Scott showed you were beautiful images, but he, more than anybody, knows that those images have to be interpreted carefully. Well, here's the dual scan technique. The fiduciary markers are placed on the denture. The patient is scanned with a bite registration along with the appliance. And then in the second phase, just the appliance is utilized, ultimately leading to a merging of the technologies. And I actually learned something today listening to Scott, is I need to think a little bit more about the accuracies of merging the optical scan along with the scan taken of the appliance. So ultimately what we see is the outline of the prosthesis, the bone, the lip support, all of these entities are there. So let's talk about masking. A little bit different with cone beam perhaps, but we would like to dissect the anatomy. And we have the ability to do that. And it has to do with the different Hounsfield densities on the grayscale in order for us to make this interpretation. And so let's take a situation like this. We have a cross-sectional view with an implant that's been placed along with the scanning appliance. And through various features in the planning software, we can insert, or what's called clip art, to insert the two-dimensional view into the three-dimensional view along with the appliance. But now when you look at this reconstruction here, you might be thrilled about the crestal bone and its potential for width. But the reality is that the density of the flange on the scanning appliance has distorted our ability to create a 3D image. So how do we go from an image like this and then incur a depends moment like this? And this is what Scott was showing you on the case just recently. And we look at it vertically, and the goal here was for an immediate implant placement supported prosthesis. Well, I can tell you that if we didn't plan ahead of time, if this becomes the point of surgical discovery, this is a difficult moment. Now, there is no commentary on whether the images that you see are in fact alive. Is the bone alive? Has your bone graft worked? It tells you nothing. It captures the calcified structures. And what about this situation? Do we really believe that we can draw the inferior alveolar nerve there and expect it to be in that position? What type of incision designs are we going to consider when we get into this amount of mandibular atrophy? So, let's look at artifact. Artifact exists every day in our patients if they have restorations. And what we're looking at here is artifact that's created by this implant that was placed. And I'll show you this case in a little bit more detail and how we overcame that. But this is artifact. This is not normally occurring anatomy. And the atomic weight of the posts or the metal restorations create beam hardening and basically zone out the entire image. That image doesn't exist in reality. And so you may have to decide that a more traditional approach to implant placement may be the method of choice rather than guided surgery. Let's talk about guide options. Now, why am I talking about guide options? Because the first place to start is not with a surgical guide. The first place to start is where you traditionally are in your practice now, but infuse your surgical experience with more information and more knowledge. So let's talk about the use of this information, but no guide. Essentially, no guides for the osteotomy and no guides for the implant placement. Let's take a situation like this. 18-year-old female, undergone orthodontic treatment, teeth are in a Class 1 relationship, but we have a Class 2 skeletal pattern. Well, this may not seem significant in this view, but when we look at the appliance, the scanning appliance, and we see that the canine is only 6 millimeters in vertical height, something's wrong. So we're going to need to plan vertical position of the implant, and this is a Class 2 skeletal relationship. Unless you have exostosis, you don't find the buccal bone to the facial or buccal of the tooth. This ultimately led to a successful end result, mainly the result of having good information. How about this situation? Yeah, pretty typical panoramic view, although this is a CT-generated panoramic view. But look at the anatomic defects. Look at the defect here in the number 8 position, and the same exists in the number 9 position. If you're talking about now taking a periapical x-ray, extracting this tooth, doing an immediate implant, as soon as you go through the apex portion of that extracted tooth, you are in nowhere. You are in nowhere. And if you do it flapless, you're even in greater nowhere. So let's take a look at this case clinically. It's still not overly intimidating at this point. Tooth number 9 was taken out. That looks pretty okay. But look at this. You ever been involved in a surgery where every word you say has an echo to it? Well, this is that type of situation. And in fact, the area was managed successfully, ultimately leading to a successful end result, as you see here. But let's go another step further. Ankylosed tooth, root resorption, infraocclusion. How are we going to manage this? Well, the reality is that you can't take this tooth out any way other than surgical. And it's interesting to note that this apex goes right up into the piriform recess. So if you want to do minimally invasive extraction, open the area, see the sites, know what you're getting involved with, know exactly what the issues are, select a surgical modality, in this case piezo surgery. It was easy to remove the crown. Piezo surgery was used to section the tooth vertically, and we took the tooth out in components and grafted the area. Well, to me, this is minimally invasive because we've preserved some pretty critical anatomic landmarks for bone regeneration. And so when we move forward here and ultimately allow healing to occur, this being the CT cross-sectional views with the scanning appliance, we elected in this particular case to go ahead and place the implant manually. So this is the placement of the implant without a guide. The bone was so robust. I mean, look at this. This bone is so thick. It was a pretty straightforward procedure, and I agree with what Scott said. There are no slam dunks. There absolutely are no slam dunks. And when you start thinking about a slam dunk in this technological environment, it will bite you. So this was the provisional restoration that was placed at the time of implant placement, immediate load, and this was the final restoration as you see here.